Final module. During the induction phase, follow up 1 to 2 times a week until dose is stabilized. Even at the stabilized dose, it may require a follow-up still every 1 to 2 weeks. In the maintenance phase, PCP can play a huge role assuming care of a patient in the maintenance phase and stability phase. Follow-ups are not as frequent, they're every 1 to 3 months, and it depends on patient stability. The follow-up interval may extend if a patient is returning to normal life. A full description of a follow-up is included on the right of this overhead, but can be found in the CRISM guidelines. Every follow-up should include an assessment of cravings, withdrawal symptoms, satisfaction with dose, side effects, if they are using or not using, and if they have any psychosocial supports, for example, addictions counselors or psychologists. UDS and other labs may be ordered at this time. Assessment of carries and adherence, especially in conjunction with information from the community pharmacist, may help with your follow-up. Follow-up regarding OUD may be the primary focus in the beginning. It may become part of a routine assessment where management of other comorbid conditions and preventative healthcare may be the new focus. Community pharmacists are a huge asset on your team. They play a crucial role with assessment and follow-up in collaboration with RODP and with PCP. They see the patient daily and or weekly and develop a close relationship with them. They can help identify issues with adherence, drug coverage, or intoxication. RODP relies on community pharmacists to assess withdrawal symptoms using COWS or SOWS during buprenorphine and naloxone induction to prevent precipitated withdrawal from occurring. If patients are transferred from RODP to primary care for maintenance therapy, pharmacists can help with bridging information gaps. They know the patient well, they know their history of use and their personality, and will likely have a close relationship and can answer any questions you may have. Pharmacists can refer to dosing from the Alberta College of Pharmacists ODT guidelines. Prescribers and pharmacists should have a plan for missed doses, for example, how to contact a physician for a dose change. Note that pharmacists cannot adjust doses and need to contact the prescriber. Therefore, a plan for missed doses should be created in case a prescriber cannot be reached. For buprenorphine, dosing is more forgivable. If 1 to 4 doses are missed, the same dose can be given. If 6 or more consecutive doses are missed, dose adjustment may be required, depending on the dose they were on previously. The pharmacist may choose not to dispense the drug if the patient is intoxicated and or under the influence of other substances. The pharmacist would then notify the physician. Methadone dose adjustment is included, but will not be discussed. UDS are fixed and or random, but primarily random. UDS for methadone must follow the CPSA guidelines. Suboxone does not have any UDS requirements, but are included as part of a full patient assessment. They're typically performed more frequently during initiation. The schedule varies depending on many factors. For example, patient factors like stability, whether they are still using or not. UDS is not meant to be punitive. A positive result does not automatically mean revoking carry privileges or discontinuing treatment. It can be used to guide treatment, for example, increasing the dose for adequate craving and withdrawal symptom treatment, or it can be indicative of adherence. Community providers use municipal labs. There is no confirmatory testing available, only presumptive positive results, i.e., someone could have a positive result for a drug class, for example opioids, but will not be able to specify which opioid it was positive for. RODP uses a different lab, the Alberta Centre for Toxicology in Calgary. UDS typically consists of 5 drug classes: amphetamines, benzodiazepines, cocaine, opioids, and oxycodone. Again, Edmonton labs provide presumptive results only without confirmatory testing. UDS also includes either buprenorphine or methadone, depending on the treatment the patient is receiving. Methadone can be tested as either a metabolite in urine or methadone unchanged in the urine. This will not be extensively discussed in this presentation. Spiking is a 0 or low EDDP concentration with high methadone concentrations in urine. If spiking is present, it is likely the patient is pouring methadone into the urine sample. As a note, urine concentrations are not indicative of serum concentrations and cannot be used to predict a response. A methadone serum concentration can also be measured. AHS lab services indications for testing include determination of compliance, elimination half-life, and appropriate dosing regimens, or toxicity. Overall, it could be used for therapeutic drug monitoring, but it is not commonly used. We are titrating to an appropriate dose based on clinical response, e.g., control of cravings and withdrawal symptoms, not a laboratory level. Typically, methadone doses will be between 60 to 100 milligrams per day, but some patients may require a higher dose if they are individuals with high intensity use or have high clearance. UDS is an important tool, but may not always be indicative of the patient's full history. It is a snapshot in time, indicative of the past 3 days. For example, a patient may not have used in the past 3 months, but used the day before a random UDS. Abstaining from other drug use, taking care of their family, and going to work for 89 out of 90 days is pretty good, but that's not represented in the lab tests. AHS regional labs do not have confirmatory testing and report presumptive positives only. We need to be wary of false positives, especially since it impacts the patient's life. If there is a positive UDS for any drug, what are the implications? The initial reactions are that the clinician might consider decreasing carries or confronting the patient. A positive UDS result should not always affect treatment decisions. Reducing carries may increase barriers for patients to access medication, resulting in more harm. It may be indicative of adherence, but overall will not drastically affect the dose or choice of OAT. Approach the patient from the view of harm reduction. UDS may not be useful if patient-provider relationships. UDS may not be useful if the patient-provider relationship is respectful and trusting. There is a limited benefit of UDS if the patient admits to using a certain substance. Try to maintain an open dialogue with the patient. As we move to the highest treatment intensity, we tackle the specialist-led alternative approaches. These include slow-to-release morphine and injectable opioid agonist therapy, like diacetylmorphine and hydromorphone. These are not currently available from RODP, but may be options in the future. Naltrexone is another alternative for treatment. This presentation will not discuss naltrexone in great detail, but it is included so that you are aware that oral naltrexone is available as a treatment option, although it's not currently used at the RODP. Injectable naltrexone is available in the US, but not in Canada. Between the two formulations, injectable naltrexone has the best evidence for its use and is typically used in the USA for patients who may want to be abstinent and fear that they may use again. In this video, we look at the ideal characteristics of an HCP.
So I really never had any good experiences with the healthcare system when I was using. I do now, but when I was using, I was talked to in a very demeaning way. They wanted me out of the office as soon as possible. Sometimes I would book appointments with a doctor because one doctor wouldn't see me anymore. And so I'd book an appointment with another doctor, and they would book the appointment and I would get there and then they would tell me the doctor wouldn't see me. I know it's because I would go in there asking for help, right? I would say, hey, listen, I'm not here for any pain medication. I am an opioid user, but I'm not here for any pain medication. I'm just here because I need help getting off this drug. I've been trying it for years and I can't do it. And they wouldn't help me. They wouldn't point me in the right direction. They wouldn't give me any medication to help the bone pain or anything like that. They would just say there was nothing they could do for me. I went in one day because I felt I was dying. I had gone to the detox center and they wouldn't let me in. It was my third day of going to the detox and not getting in. And so they sent me to the hospital in order to make sure that I was okay. I got to the hospital and I ended up waiting there for 16 hours. I watched 4 or 5 groups of people go in before me. So I politely went up to the front and asked if maybe they had forgotten my name, or maybe they had they missed the paperwork or something. And I was very polite about it, and they said, oh no, the most important people will go first. And so I laid back down and I waited a couple more hours, watched another group of people go in. Finally, I went in, and they had me in another triage area where I waited for another couple hours. The doctor came out and he gave me an Ativan. He called me a junkie, and he told me to get off the premises before he called security. And so that was like one of the worst experiences of my life. I was sick. I was sent there by a detox, so I felt like it was supposed to be a safe place. I got there, I was told that I was unimportant. I was one of the least important people there. I felt like I was dying, and I wasn't looking for drugs. I was just looking for help. And then I get told that I'm a junkie, and then they kick me off the premises when I have no ride or no phone. And so I couldn't even get anyone to come pick me up. And so I'm sick with no treatment, no proper treatment. They gave me an Ativan, which made me go to sleep. Like I was still sick and I had no way of contacting anyone. It made me feel like I was an animal, like a dog kicked outside after dinner or something. Like, we're people. Sorry. The number one thing I'd like to see in the healthcare system would just be compassion and love, and kind of just like an understanding that like if people come back after being clean and they've relapsed, to just understand that relapse is a part of recovery, and to not have too high expectations for people when getting clean. Another thing that I'd like to see is, doctors being able to point people in the right direction. Like, here's a treatment center, here's a detox center, like this is the best person to get a hold of, here's some addiction counselors' numbers, instead of just pushing them away. Another thing I'd really like to see, but I don't think it'll be possible, is for you to go into a doctor's office and say, hey, like, listen, I need Suboxone, I need Methadone. Because honestly, it's extremely hard to get on these programs. And so if it becomes too hard, addicts aren't gonna do it. It would just be easier for them to go find it somewhere else.
Remember that OUD is a chronic relapsing condition. Relapse is to be expected. For the patient, relapse is commonly associated with shame and guilt. Patients may lie if they are using again, or they may not want to seek treatment again for fear of judgment or chastising. Clinicians can play a huge role in breaking down that barrier by responding with empathy and understanding. Acknowledging the past. I am glad that you are seeking treatment again. The past is the past. Let's move forward on a new slate. Phrases such as this may be very impactful for a patient. From there, identify where the patient is on the stages of change and respond accordingly. Creating a mutually respectful patient-provider relationship is essential to optimize treatment. Patients may feel more comfortable disclosing relapse, use, or asking for help if they believe you are on their team. Primary care providers are in an optimal position to play a role in the management of OUD patients. Acknowledging that there are many barriers in practice, such as time availability and staffing, PCP may find the easiest way to transition into OUD care is to take over care of stabilized patients from ODP clinics. In this role, OUD follow-up may only play a small role in the assessment of this patient and may eventually evolve into preventative care. Other areas that PCP can provide care for is in the treatment of comorbidities such as mental health conditions in current ODP patients. They should try to optimize best opioid prescribing practices to all patients within the clinic. Overall, OUD patients are often complex cases and may benefit from a multidisciplinary approach. Consider getting a working relationship with a community pharmacist or other professionals within the community. Rapid is an AHS phone service with addiction specialists answering questions from all primary care practitioners in Alberta. This is great for primary providers who may not have much experience in management of OUD and are looking for guidance. There are open on weekdays, weekends, and statutory holidays. Note that there are different numbers for different regions in Alberta. Also note that they do not offer chronic pain consultations. If you are looking for pain resources, there are links to the Calgary Pain Management Centre in the resources slide, and this may offer you more information.
The number one thing that I would say is to not lose hope for us addicts, because we do recover. Like, I'm a mother of a beautiful child. I have an amazing husband. I have a home. I have a garden. I have a job. You know, I play a part in my community. I volunteer. I do all these things. And I was once that junkie that nobody wanted to talk to. You know, we are the same people we were before the addiction. It's just the drugs cover up that personality. And if we get the care that we need, if we get the proper treatment and the proper support networks, it's possible. We can recover.